uh, uh, the series of the webinar, which is almost from the 6 months we have conducting this series of webinar from the National NCT Division for the all the participants from the states, districts, and below district level. So today's topic is cervical cancer under the National Program for Prevention and Control of Non-Communicable Disease. So, with the permission of the chair, uh, Dr. Swasti Charan, Additional DDG, Director General of Health Services, Ministry of Health and Family Welfare, as the HOD for the National NCT program. So I would like to have some words from the sir so that we can initiate this webinar, today's webinar on cervical health, sir. Yes, sir.
Thank you, Sunny. Good afternoon, everybody, and welcome to all the medical officers, CHOs, healthcare workers of the NPNCD program, and many other health professionals who have joined this webinar today. This is one of our ongoing fortnight webinars from the National NCD division here in the DGHS. And today's topic is cervical cancer, which is a major public health issue in our country. Friends, we all know that cervical cancer is one of the leading cancers affecting women in India with significant morbidity and mortality rates associated with it. The National Program for NCD aims to enhance our awareness, screening, and prevention strategies to combat this preventable disease effectively. There are various factors which is associated with this issue, one of them being low awareness levels. Studies in India have also shown that awareness regarding cervical cancer and its prevention is relatively low, particularly among Indian women in the rural areas where the socio-economic factors hinder access to information. We also have other issue of the need for targeted education where campaigns to inform women about the risk factors, symptoms, and importance of early detection has to be emphasized. Therefore, the Ministry of Health has taken a lot of steps, one of them being the screening camps that we have for three cancers, one of them being cervical cancer. We have also enhanced the effective screening methods by using VIA. We have also engaged the community for full participation, and we are trying to address the various barriers, including cultural sensitivity, and also trying to empower the women in this country. Friends, today's webinar is going to be very interesting. We have got a very eminent speaker who has been working in years for years in the All India Institute of Medical Science in New Delhi, Dr. Nirja Batla. He is associated with in a way synonymous with treatment of cervical cancer in this country. And we hope that this webinar will enhance knowledge and the skills of the healthcare workers in this country. So we am very excited for this webinar, and I would request my team to take it forward. Dr. Sunny.
Thank you, sir. Thank you for these words, sir. I would like to introduce our today's speaker on cervical cancer, Dr. Nirja Batla, ex-professor and HOD, Department of Obstetric Gynecology and AIMS, New Delhi, and she is also the Vice President of OXI and consultant to WHO IARC. I would like to uh, give these few things about the cervical cancer and ma'am that she worked very hard for cervical cancer prevention and control throughout her career, and uh, her her point and the expertise always give the remarks for our operational guidelines, technical guidelines. So it is very graceful to listen to her, and we will have the another uh, expertise on these topics. So I welcome Dr. Nirja ma'am uh, for her technical session on today's topic, cervical cancer. Over to you, ma'am.
Thank you very much for the kind introduction, Dr. Sunny. Good morning to Dr. Swasti Charan, additional DG sir, and all the eminent people in the hall, and all the medical officers and the people that we have in the audience, all the nursing officers, all the health workers, and all the people who are so important to take our programs forward. And indeed, it is a very suitable topic because January is the Cervical Cancer Awareness Month. And who is there to do this for us except our field workers who are our main force on the ground? So, with these few words, I would like to share my screen now and start my presentation, which is on this topic of cervical cancer prevention and elimination. And elimination of cervical cancer is such an amazing thought that a cancer can be eliminated and that we can reduce the public health problem that it is today. Because this is the second most common cancer among women in India. The number one is breast cancer. And you know that we have a screening program of breast, cervical, and oral cancer, which is supposed to be done at all times in all the women who are aged more than 30 years. And we can see from this that it is the poorest parts of the world which have the highest levels because of being such a preventable cancer, but not being able to implement the tools. And now the WHO has specified which are the interventions according to the life course, because we know that it is an infection by a virus that is causing. This is why it is so preventable. Prevent the virus infection, prevent the cancer. Similarly, we have the hepatitis B, where we have the hepatitis B vaccine to prevent the liver cancer. Now we have an infection that we can prevent by vaccination, we can detect by testing, and we can treat in a pre-cancer phase. This is something which is unique of cervical cancer, that it has a long pre-cancer time, 5, 10, 15 years before the cancer comes. Simple changes can be detected and simply treated. So for the girls before 15, best age to give the vaccination, although we can give it any time till they get married. Women more than 30 years should be screened. WHO now says do 35 and 45 years. And these simple treatments, we will see now what can they be. And all the women who get detected with cancer, we should find a way to refer them to the nearest cancer center to get the proper treatment. Early stages may be surgery, later stages may be radiation, along with the radiation may be chemo. And the late stage patients, we must never let them give up hope. We must give them palliative care. They must live their lives with dignity and comfort. So, because of discovering this HPV cause, because of having tools like vaccination and testing and treatment, WHO said we can eliminate cervical cancer as a public health problem if we have intensified vaccination, screening, and treatment. And they have made a target that by 2030, we should have these targets in place in all the countries. And India has also signed this declaration. And we hope that if we can do this, eventually we will reach a target less than 4 cases per 100,000, which is a rare cancer. So how will we do this? By doing 90% vaccination before the girl is 15, by screening women by HPV test at 35 and 45 and 70%. And in this, I'm happy to say that we are making good progress with testing our Indian HPV tests and finding out which ones are suitable. And hopefully we will have this program in the program also very soon. And we already have the Indian vaccine. Now, this doesn't end over here, because just finding that the woman has a problem is not going to prevent the cancer unless we are treating them. So 90% at least should get treated, whether it is pre-cancer, whether it is cancer. And by doing this, we also fulfill the SDG goal, which has a target of 30% reduction in mortality from cervical cancer. So for prevention, what do we have? Prophylactic vaccines, but we must also give the primordial prevention awareness of safe sex practices, menstrual hygiene, and treatment of STIs, because we know that these are cofactors in the persistent HPV infection and progression to cancer. HPV infection is a necessary cause, but it is not sufficient, and preventing these type of cofactors will help us to reduce the impact. In India, we have multiple HPV vaccines now. The first one we had was the 4-valent. In the 4-valent, two are the high risk type, 16 and 18. 6 and 11 are for the warts. We also had bivalent, which only was for high risk type, but this is presently not in the market. A 9 type vaccine was then launched by the same company, which had more types. And now we have Cervavac, which is our Indian vaccine, which is the one we have great hopes because it will be our affordable and usable one, and that is 1618. How have these types been decided? It is by the basis of all these multiple types that which is the most common, and you can see that HPV 16, which is 62%, and HPV 18, which is 15%. So total accounting for 77, 78% globally. But in India, we have 84%, which are being accounted by 1618. So really for us, the 1618 vaccine is good enough. It also gives a little cross protection against other types. So you can say that almost 90% will be taken care by this. The studies have been done to show the efficacy and safety. Most of these studies have looked at preventing the pre-cancer. We said that the pre-cancer phase, which we call as CIN, and all the studies have shown that giving these vaccines will prevent the CIN, and it is a very safe vaccine. Although I know from time to time we hear this problem, that problem caused by vaccine, but all the studies which were done for the licensing, all the post-marketing surveillance, all our experience in India, we ourselves have had a big study of 17,000 girls, which has been the one to show that we can even give one dose safely. We started with two, now with one, and it is effective. All these studies have shown that no increase in adverse events over the rate in the general population. So maybe somebody is having some problem, but even in general population they are having, it is not being caused by vaccine. In fact, CDC said the vaccine is as safe as the tetanus toxoid, and we know that we give TT vaccine all the time to all the women very safely. So we have only been able to do CIN in the trials because CIN has to be treated. It is not ethical to leave a CIN. But from looking at countries which have had experience of recording systematically how many cancer cases, we now have real world evidence to show. The first one came from Sweden, where they looked at the girls who were unvaccinated and followed. They have very good registry systems. How many will get? They looked at the ones who got vaccinated between 17 and 30 years, and they looked at the girls who had been vaccinated before they became 17. And they found that if they were vaccinated before 17, it was an 88% reduction in cancer. And even beyond, it was a 53%. But that is why, looking at the data, it has been decided the 14-year limit. Even in UK, when they started this was the bivalent vaccine data. They also similarly found that if they were given at 12 to 13 years, there was maximum reduction in cancer, and in the pre-cancer, which is the CIN 3 plus, is the pre-cancer stage. If given in older girls, it was progressively less effective because some of these girls may be already sexually active and they may not get as much benefit. And this benefit really came so well that they said that we have now almost eliminated the cervical cancer in those females who are born after 1995, which is based on their national program introduction. And WHO, as I mentioned earlier, our own trial, many other trials, found that girls who got only one dose were also being protected as effectively. And these are trials in progress. And some randomized trial results will come by the end of this year. So next year, we expect a firm one-dose recommendation, which is presently 1 or 2 doses, not only for our primary target, which is 9 to 14, but even for those which are up to 20. And beyond that, we give only 2 doses. Now, the previous recommendation of giving 3 doses is only for those people who have immunity issues, maybe HIV, maybe transplant people, somebody who's on steroids, they get 3, otherwise not. And similar lines, the NTAGI has also made its recommendation that it can be given as a single dose for the older vaccines, but Cervavac, which is a new vaccine, we have to watch for some more time, start with a 2 dose, and then we have already had ICMR has started the study to see the benefit of 1 dose in this group. So there are also other HPV caused cancers. They include the vaginal, vulvar, penile in men, anal, and even the head and neck. So these are side benefits that will come out of giving vaccination because these are not very common and all of them are not caused, unlike cervical cancer, where 99% are caused by the HPV. So their benefit is not as much, but it is also some benefit. So here I will move on now to the second part, which is how to screen. And the first tests which came in the world were the cytology by the PAP normal, and then came the LBC. But these are expensive. They need to be done repeatedly. The cytology accuracy is not so good. So you have to keep repeating every 3 months. So we had studies on the visual methods, the VIA, and we found that the sensitivity worked, but it has a lot of false positives. Many of you may be already doing, because now it has been in our program since 2016. Prime Minister had urged that we start the screening of the 3 common cancers, and soon after, so progressively, I think many of you may be doing already these tests, and you may be seeing how difficult it is. But we do have a lot of work going on now to develop the automated visual evaluation, which means AI wala tools, which will help this. But the most accurate is the HPV, because that we know is the virus which is causing, and there are many tests coming up. And the good news with HPV is it can also be used for self-collection. Self-collection, the patient can take her own vaginal sample, we can teach them, or even the health worker who doesn't have a speculum, doesn't have a light source, doesn't have sterilization facility, can just take a high vaginal swab. And the most recent study in this direction is going on with the urine testing, which may also become a reality. So these guidelines are there, the living guidelines, which are available as a free download, and anybody who wants can access this at the WHO website. So now, getting a screening test positive, as I said, not all of these are going to get a cancer or even a pre-cancer. So we have to make the diagnosis, for which we have the older version of colposcopes that we have been using. And apart from that, now we have a lot of portable colposcopes which are coming, which are battery charged, and they can work in the field area with the battery packs. And now the newer ones are being developed, and some of these Indian ones are being developed, like Smart Scope Engine, which is still work in process because the AI is still being trained. But there is hope that eventually the health worker can take a picture, upload it to a person sitting for a remote consultation, or the device itself will tell you this patient need to be referred, this patient need not to be referred, this patient you can do a thermal ablation in the periphery area, and all. And training the health workers is not difficult, because it is easy to learn to put in the speculum. It is easy to recognize which is the original, and this is the squamocolumnar junction, very red columnar, very pink, and outside you can see there is a difference in the shade, the outermost gland opening. So this is what we call as the transformation zone, and they just have to learn how to be able to look at it, which is not a difficult thing, and to recognize some simple lesions, polyps. This is trichomonas infection, strawberry cervix, very white on application of acetic acid is worrying. We have to take biopsies from that. And this very thick plaque with very irregular vessels is definitely very suspicious. This is not something to treat. This is something to refer. And these are little polyps and other changes. So these are some things which we can teach very easily in very short courses and do a revision also. And so then we can have a treatment option, which can be ablation, which can be excision. Ablation used to be cryotherapy, a lot of problems of gas and a lot of problems of maintaining the gas pressure and so on. So thermal ablation is really the new workhorse there, which should be now considered to provide at every peripheral unit. And now these are also portable, so we can have the battery packs and do it very nicely. Excision needs a little more training, but not terribly more. And medical officers also can learn to do this and do the LETS or conization procedure. And definitely the gynecologists and the district can be trained very easily to do these procedures. And LETS can be done in the OPD setting also with the local anesthesia. So the screen and treat is actually becoming our gold standard, because otherwise people get lost to follow up, and we saw that 90% need to be treated. So the screen and treat test criteria have been defined, whether we can do it the same day without a biopsy or not. And even we can take the biopsy and send the biopsy, but not wait for the report and treat if entire lesion is visible, not going into the canal, not going into the vagina, not more than 2 quadrants. We don't think that there's a glandular abnormality extending in the canal, and we don't suspect invasive disease. But if anything is like that is there, or the patient has complaints like postcoital bleeding, postmenopausal bleeding, these must not be ignored. She needs gynae evaluation and she needs to be referred. So treating the entire transformation zone is very important, and we already discussed which is the transformation zone. And the equipment needed for ablation is so simple. All that you need is the 5% acetic acid and the Lugol's iodine, a few swabs, and sometimes you may use the condom to cover the speculum if the side walls are bulging. And this portable thermal ablator, the electrical version was there earlier, which is the desktop. Now we have the battery operated versions. And these are the equipments which you require for the LEAP, which are also rather simple equipments. So post-op advice is very important, because the patient should know that she can get some mild cramps or bloodstained discharge. Counseling patients is very important. Otherwise, they get alarmed and they spread bad news to other people and they get concerned. So they must know these things. And we must tell them that they must not have sexual intercourse for 4 weeks. They must not insert anything if they're in the habit of using sometimes some tampons, etc. And we do need to keep these patients on follow-up, and they remain on follow-up for many, many years in case there is a CIN. So the impact of HPV vaccination and screening has been studied in comparative modeling analysis for low and lower middle income countries. And it has been seen that just by doing the vaccination, you can avert 89.4% of the cases. Whereas if you add the twice in lifetime screening, you can have almost all 96.7. And this chart here shows how the dark blue are the ones which are in the zone of less than 4, which is our goal. And you will see in this the year in which we are. And this modeling shows that as the years go by, everything is progressively getting more and more blue. And India, you see, is about 2060. It is expected that India also turns blue if we are able to put in the targets by 2030, which is not very far away. So my message really today is that together we can. What do we have to do? We have to ensure that every girl receives her vaccination by 10 to 14 years of age. We have to enforce the message for screening after the age of 30. Preferable is HPV testing, and I'm very hopeful that this year we will see some Indian HPV tests being approved for this purpose. But there is good evidence for every method, VIA, cytology, everything works. So let's do whatever we can do. We have to bring forth survivorship stories. People don't come forward to say, I'm a cervical cancer survivor. There's a lot of stigma. Breast cancer, they're all happy to say, we had breast cancer. We don't want to help others. But cervical cancer, not many women, but more and more they are coming now. So we have to mobilize influencers. And we have to form the public-private partnerships wherever we can, wherever we find donors, wherever we find agencies to strengthen the program and linkages, because this is not something anybody can do all by themselves. So this month, let us try and get the message out to everybody, because certainly we can ensure a cervical cancer-free future for our women and our girls. So with that, I'll stop over here. And if there are any questions, I would be happy to take those.
Thank you, ma'am. Dr. Nivedita, this side. There is one question. Due to time constraint, we cannot take many questions today. But there is this question, ma'am. Can married women take HPV vaccine? Because when they asked a gynecologist, she was advised they are already sexually active, so they cannot take HPV vaccine. Please advise, ma'am.
So this is a very good question. I'm seeing now somebody saying about low volume. I hope people could hear. So anyway, so this is a very, very good question, very common question. So there is some benefit. There is some benefit because there are multiple HPV types. I showed you the whole long list, and everybody is not going to have every type, especially with the non-valent vaccine. There will be more types covered. But because the benefit is not so much, so we don't advise, no country advises in their national program to be made available free of cost. If patient can pay for it, there is no harm. She will not have any side effects. She can only have benefit. But most important is that in that age group, they have to start getting screened. So if the choice is between paying for screening and vaccination, the choice is very clear. She must get screened first. If she can also afford the vaccine, she is most welcome to take. But national program will focus on the 9 to 14 year age group people. Second one, about the video being made available offline, from my side, you're most welcome. Please take the video, no problem. So the contraindication and side effects, as I said, there are very few contraindication. There are only if somebody is allergic to that the components of the vaccine, which is really not much applicable. And side effects are just the common ones which any vaccine will have, like pain, erythema, some headache, somebody may say nausea, somebody may have a little fever, but we have never seen really that they have to stay home because it was so severe that it could not be managed. So does CIN1 also require treatment? So normally we say that for 2 years, if the CIN1 is persisting, then we should treat. But in the CN treat programs, we do treat CIN1 also. So it depends which way we are going. And any antiviral treatment for HPV? So no, we don't have any antiviral treatment so far. WHO has started a program to develop a therapeutic vaccine, and maybe that will come sometime. But right now, none of the antivirals will clear it. Our own immunity clears 90%. It's a very common infection. 85% of women and 90% of men get this at some point in their lives. But most of them clear it like we clear a common cold with their innate immunity. But in this case, it doesn't clear in 1 week like common cold. It takes up to a year to clear sometimes. But 10%, up to 10% can have persistent HPV infection. This is the group which is at risk. So which vaccine is available at present in government or public sector? So at a national level, no vaccine is available. In Sikkim, they are doing vaccinations. In Bihar, they have recently started and have initiated tendering. At present, the government program is yet to start. Is there any training for medical officer at district or state level? So this will be answered, I suppose, by the program people. And the HPV vaccine, which will be introduced, also will be as per their methods, I'm sure, the processes of tendering and getting, so whatever. And what should be advised when PAP's report is ask us now, this woman needs a colposcopy. For sure, it is good to get a colposcopy and see if there is any abnormal area. If colposcopy is not available, you can also do a VIA and see if there is any whiteness, which is in relation to the squamocolumnar junction. And you can take a biopsy from that and send it. But definitely needs a further evaluation. So yes, screening is first choice, and normally they say that screening and the vaccine are not necessarily to be linked, because even if there is something in the screening, then the vaccine will take care of other parts. So the screening and vaccine have not really been linked for these older women. Can I take HPV vaccine after 30 years? Yes, the vaccines are licensed till 45 years, so you can take the vaccine. Recently, no legal notice have been served to states. So this has been served by some anti-vax groups, and that has no bearing as such. But if the states are really the ones who have to respond to that, as of now, the vaccines are licensed by the drug controller, and there is no problem in prescribing the vaccination. Of course, the person should not be vaccinated without their consent, and they must know that there are side effects, as are in any vaccine. Minor side effects are there. The majority of gynecologists are not confident in conducting BIA, so we would advise them to definitely take the training through the government programs. And there are also societies which are constantly doing these trainings, like the Indian Society of Colposcopy, the Aogen India Society, in their annual conferences and their CME programs. So you can definitely get in touch, and we can help anybody who would like to get this treatment. So this question, I don't know any side effects. So no, it's not mandatory. Now, no vaccination is mandatory. All vaccines are by consent of persons. And do not recommend any vaginal shampoo. No, the basic vaginal hygiene, basically we mean that they must keep the part clean. They must bathe in the well and keep the part clean. Make sure they are using clean clothes and underwear, and you have the proper methods of menstrual hygiene. And over 50 is no point in taking the HPV vaccine, because after the menopause, the activity in the transformation zone dies down and not required. Adolescent boys can receive the HPV vaccine. It is safe and effective in immunogenicity also, but it is not in the national program presently, because we have to first target the girls. BIA can be done after 30 years and can be done every 5 years. And what is the treatment of swelling of endometrial layer of uterus? And all this will require an evaluation, treatment with antibiotics if there is infection, and an endometrial aspiration will have to be done. Where the video will be put offline, they will let you know. Both male and female may be vaccinated. The male will have to buy the vaccine. The female may get covered in due course soon, we hope. Then which vaccine is best? All the vaccines are good in India, because as I showed you, we have very high proportion of 16, 18. So all are just fine. And if a woman develops warts on the neck, so the warts which affect the neck are different. The HPV types are different for every area. They're very tissue and species specific. So these will not be the same type which are causing cervical cancer. But in any case, the cervical cancer screening should be done. So in Haryana, vaccination is stopped means I don't think it was started in the government program, and it is not stopped for the persons to the gynecologists who are in their practice. And yes, Servavac has passed all the regulations, and that is how it is licensed. And age of 27 can take vaccine, yes, and whatever vaccine they can get is fine. And at age of 27 they need 2 doses at 6 months minimum difference. And when we give the vaccination, precautions which we must take is to keep the person under observation for next 15 to 30 minutes, and they should not leave the clinic, because some people can have a little giddiness or something, and we don't want them to go out and fall down. So that is all there is, and nothing else is this thing. And is it necessary to do VI? Yes, because the vaccines are not covering 100%. None of the vaccines covering 100%. So as of now, the screening recommendations have not changed. The vaccine they will take before they are 15. After they are 30, they will get BIA if that is all that is available, but HPV test will be the best. If patient is HPV positive and pregnant, she can definitely continue with the pregnancy. There is nothing wrong with that. And all she needs is to examine the cervix and see that she doesn't have a lesion, and then follow up 6 weeks after the delivery. And is it necessary to perform cervical? No, cervical biopsy does not need to be done under GA. Cervix is very tolerant. Only problem is with childbirth, which causes stretch and pain. So biopsy, thermal ablation, freezing, cutting with local anesthesia is more than enough. It does not require, yes, can be done in the OPD, absolutely. So,
Ma'am, uh, can you hear me, ma'am?
yes.
Ma'am, actually, thank you for taking so many questions. But ma'am, we are a little over time now. I think rest of the question could be answered later. So thank you so much for a wonderful presentation and so much information that you've given to us. And thanks for
On
this
behalf
webinar.
of NPNCD team, I extend my heartfelt gratitude to Dr. Nija ma'am for delivering such an enlightening webinar on cervical cancer awareness. And our sincere appreciation goes to ma'am as well for providing comprehensive insights into cervical cancer prevention and highlighting the importance of early detection and treatment. Your expertise has empowered our community health officers with invaluable knowledge that will undoubtedly contribute to reducing cervical cancer risk and improving women's health outcome, ma'am. We are grateful for your time, dedication, and commitment to public health education. Thank you, ma'am. Thank you all for
Thank you.
joining.
Hello.
Yes, good afternoon, ma'am. Ma'am, this is
Yes,
Dr.
ma'am.
Nidhi. Hello.
Yes, ma'am. We can hear you, ma'am.
Ma'am, if you are speaking something, you have to unmute yourself.
No, I thought this was a very nice session, and thank you for inviting me. And very nice to have such an interactive audience.
Thank you so much, ma'am. Dr.
Thank you so
Shweta,
much,
shall
ma'am.
we wind up the
Yes,
session?
yes, yes. Thank you so much, ma'am. It was really a
Thank you,
very
ma'am.
interactive, very good session. Thank you so much, ma'am, for taking out time. Please close
Thank you,
the
Dr.
session,
Shweta.
Naresh.
Thank you, Dr. Nivedita. And thank you, Dr. Nirja, ma'am.
Thank you.